Well, welcome back, everyone. We are here for another dose of Joint School, and today I'm honored and thrilled to have with us Dr. Paul Jacob.
Well, hello, everybody. I appreciate the invite, and this is a real honor for me. I'm an adult reconstruction surgeon, so I focus on hip and knee replacement. I'm in the United States in Oklahoma. I was born and raised in Akron, Ohio. Ended up doing my training at the world famous Cleveland Clinic. That was a really great honor for me. Happy to bring that knowledge and skill here to Oklahoma. And we're here to hopefully have a good discussion today about joint replacement.
Absolutely, absolutely. And the discussion we'll be having today is about the uncomfortable topic of pain, and particularly how it relates to knee replacement. And of course, pain is sort of the center stage villain and driving force really of most joint replacement surgery. And it's also probably the most common question that we get sent into us, either via the My Recovery app or here to Joint School. And so we'll be exploring a bit about expectations around pain, the different stages of recovery, and also what we can do about it.
Absolutely. You know, it's the number one question I get asked, and the data from the American Academy of Orthopedic Surgeons is really clear that 80 to 90% of patients who are a candidate for a joint replacement, in particular a knee replacement, often avoid it because of their fear of postoperative pain. So it's a really important topic to discuss, not just with patients, but in general.
Yeah, absolutely. And I think, I mean, it is also important to highlight, because it is a daunting topic, but it's important to highlight that for most people, knee replacement is a treatment for pain, and it's a very good treatment for that.
Absolutely. You know, we look at the short-term, mid-term, and long-term data. The demonstrated value is there. So we know we get you back to work, we get you back to activity, you enjoy the things that you love to do. Things like depression and anxiety start to subside. Your weight gets back under control. We can help with management of chronic medical conditions like blood pressure and diabetes by getting you active and keeping you from sitting and becoming sedentary and gaining weight and adding to all those problems.
Yeah, absolutely. I mean, and only recently there's been some really significant studies showing just how positive an impact a joint replacement can have on quality of life and all these other factors that you've mentioned.
Yeah, absolutely. Especially in places like Canada and Europe, where you have nationalized healthcare, demonstrating value is essential. So in these types of nationalized healthcare programs, knee replacement is one of the most common, if not the most common procedure performed on the patient population. So not only demonstrating value, but continuing to add to that value with things like multimodal pain control are really important in determining what's useful, what do we keep, and what's not useful, what do we get rid of, in treating patients both before, during, and after surgery.
Yep, certainly. Now, you mentioned multimodal pain control, which may be a term that not everyone is familiar with. So let's dig into that. But should we start perhaps with the main or the most common questions that you encounter in clinic and with your patients around pain in terms of knee replacement?
So we can break that down into before surgery and after surgery, because those two sets of questions are very different. But before surgery, I get asked, you know, how much pain am I going to be in? And that's a really difficult question to answer because it's patient specific. There are some patients who swear they had very little to no pain after a knee replacement. There are patients who really act like this was the worst thing that they had ever been through. And I totally understand that. But as a surgeon, when we talk about preoperative pain control, we have a set of criteria in particular here in the United States that we like to work through as far as preoperative management of osteoarthritis pain. And that includes weight loss and activity modification, over-the-counter and prescription medications, physical therapy, injections, bracing, and the use of ambulatory aids. So that's our kind of baseline conservative care. That's what we focus on. That's how we check boxes for the insurance companies to make sure that these are good candidates for surgery. But there are then things outside of that initial bubble that can also be effective. So in combination with things like anti-inflammatory medications and analgesic medications like Tylenol, physical therapy and weight management, We have things like nerve ablation procedures, and these are fairly new on the landscape of preoperative pain control in particular. You know, genicular nerve ablation often came out of failed knee replacement treatment for pain for failed knee replacement. And so doctors, the pain management doctors came up with this procedure, and the interventional radiologists and several others. And this was to treat a patient who had a knee replacement, but was still suffering from kind of chronic low-grade pain. And then as surgeons, we started to look at this and say, if it's great for post-operative failed knee replacement, what about preoperative pain control? And what about perioperative pain control? So for a patient who we're not trying to avoid surgery with, but we know they may struggle with pain after surgery, is this procedure helpful? And we don't have all the data yet on that. We're really starting the early research process, but my anecdotal data, you know, out of my clinic and out of my practice has been exceptionally well received by patients and by the perioperative management team, who have, you know, the responsibility of controlling symptoms adequately enough to get these patients through physical therapy.
Yeah. Now, of course, you know, as with all of the conversations we have here in the Joint School series, it's worth reiterating that, you know, as with all aspects really of any medical treatment plan, you know, pain management is very much, you know, going to be personalized to each individual, and it's also going to vary somewhat between surgeons, between departments, depending on the underlying condition. And so, and also there are some things that we may discuss, such as genicular nerve ablation, that may not always be available at all sites. So
and it may not be indicated for everybody. Yeah, things like anti-inflammatory medications. If you have, if you've had a nephrectomy or a kidney removed for whatever reason, you may not be a candidate for things like that. It's not a cookie cutter package that we deliver to every single patient. Truly, that pain control is tailored to each and every individual patient. So, you know, narcotics and opioids play a role. They are not the only form of pain control after surgery. Neither is an anti-inflammatory medication or any non-opioid analgesic like Tylenol. We use these things in combinations of opioids, Tylenol, anti-inflammatories, nerve ablation procedures, injections, blocks before and after surgery. You know, all these things are a part of, even the anesthetic that you choose are a part of pain management, and setting realistic expectations is also a part of pain management. So helping the patients understand what's normal and not normal and what to do in those scenarios brings your anxiety level down, which also then can help to control your pain.
Yeah, absolutely, absolutely, and that's the, you know, the term you mentioned earlier about multimodal pain control. That's exactly it, right? It's just the same way that the knee replacement procedure itself is no silver bullet. You know, its success relies on prehabilitation, rehabilitation, you know, a lot of other factors, and it's one part of the puzzle.
Yeah, prehab or pre-physical therapy, I think, is a really important part of multimodal pain control, and that's sending patients prior to their surgery to prepare for a surgery. We don't do that in most surgeries. This is a pretty rare scenario. And the data is really good on prehab and pre-physical therapy, decreasing both the amount and the frequency of physical therapy needed after surgery. Understanding how to do those exercises correctly prior to somebody rebuilding your joint makes the post-operative both anxiety and worry about what those exercises are going to be like, and your concern about, am I doing them correctly? That all comes down after surgery. And so incredibly valuable. It's another part of the multimodal pain control treatment plan.
And so before we move on to sort of maybe the later stages of recovery and how the pain might evolve as one sort of gets back to normal, so to speak, after the surgery, would you mind telling us a little bit more about genicular nerve ablation and how it works and when it's the right thing and when it might not be the right thing?
Yeah, so that's a great question. I'm glad we're going to chat a little bit about it, because everybody isn't a candidate for this procedure. You know, you don't start with genicular nerve ablations. It's really a part of the treatment path as you move past the early treatments like weight loss and activity modification and medications that we talked about. But when those things start to fail and you're either not a candidate for surgery, or you're not ready for surgery, or you're preparing for surgery, but you want to decrease your post-operative pain, this can be a part of that. And so 2 to 6 weeks outside of surgery, or at any time if you're managing a non-operative patient, you can send for a genicular nerve ablation. And that's where we really kind of deaden the nerves in 3 spots: the superior medial, superior lateral, and then the medial branches of the genicular nerve, the inferior medial branch. And we can use a radiofrequency device. We can use a device that heats up and deadens the sheath around the nerve, or some of the newer cool technologies that still ablate those nerves. And all of them have advantages and disadvantages, but accomplish the same thing. And that's to decrease the sensory pain that's coming from the inside of that joint without affecting motor function.
Okay, interesting. But with ablations, we're essentially talking about, in a way, damaging the normal function of that nerve and how it's able to send back pain signals.
Yeah, and so that damage most of the time is temporary. It can last up to 18 months. It can be as short as 2 or 3 months. And the process occurs in 2 steps, sometimes more than 2 steps. But the first step is a temporary block done with just numbing medication or numbing medication and a corticosteroid, depending on who's doing the procedure and their preferences. And that gives you a short-term window into determining whether that is going to be helpful and effective for your post-operative or preoperative pain control. And so it gives you a little 3-hour window into seeing what it would be like to have those nerves ablated. If you get 50% reduction or greater in pain relief after the temporary block, that's when you would move on to the more permanent version of that block. And there are multiple different ways to ablate that nerve. Most are temporary. There are some that can be more permanent, but each of them is somewhat effective in treating that pain.
Okay, interesting. And have you found in your experience that it can be at all sort of indicative of how effective the actual knee replacement itself might be in terms of treating an individual's knee pain?
Yeah, that's a great question. It isn't quite as predictive as a steroid injection would be, or a diagnostic injection maybe in the hip prior to surgery. But so what I usually find is patients who are severe, meaning they have a lot of deformity and a lot of fixed bowing or change to the alignment of the leg, don't get quite as much relief as patients who are in moderate or early severe arthritis. They seem to get a little bit more relief, and that just, I think, makes sense in general. Once the joint is so deformed and so severely changed, you even start to affect joints above and below, and there's a lot of pain generation, not just from the joint itself and not just from the inside of the joint, but from the structures surrounding it.
Okay. And are there any particular risks of the genicular nerve ablation procedure itself?
Yeah, so you can damage the soft tissue and ligaments and tendons around the area that you're ablating. You could damage a motor nerve if you're too close. The upside is that you introduce an electrode that tells you where you are and what nerves you're close to, so that you decrease your risk quite a bit of damaging nerves you don't want to damage, while still being close enough to the nerve you want to cause damage to get effective pain relief.
Okay. And while that pain relief is in effect, will there be any sort of numbness over that area, or does that last as well?
Yeah, there can be. There can also be skin burns, around that area. I've never seen it myself personally, but the literature says it's a possibility. There is some numbness around that area. The genicular nerve itself does not supply any skin sensation. So if you do get some numbness, it should be temporary from the numbing medication used during the procedure. Okay.
Well, so before we move on from genicular nerve ablation, then, is there anything else you'd want to add, or that you feel we haven't covered on that?
Well, there's a couple of different ways to use it. It's preoperatively to avoid surgery. And, again, there's been several studies published on its use with management of osteoarthritis pain. And it's a part of the treatment regime, not the only part, but a part. The great thing about it is it's not medical in that you have to take a pill or you're affecting other organ systems. It's really predominantly a procedure that affects the nerves that are supplying the pain from the inside of the joint. You can also use it as a preoperative adjuvant to help control post-operative pain. And this is the newer way we're using genicular nerve ablation. So 2 to 6 weeks prior to surgery, you have that nerve ablated. Then we hope for a 20 to 30% reduction in post-operative pain from that nerve procedure. And that's what I see anecdotally. We don't have enough data yet to say definitively that that's what we're going to see. Some patients I've had more, some I've had less. I've had patients who say, I don't think it did a thing. I've had patients who say, I don't think I could have done it without it. So like all other, forms of pain control, what works for one may not work for another.
Yeah. Okay, interesting. And so we've mentioned a bit about some of the other options beyond more sort of direct localized approaches, weight loss and different types of pain relief, and also about setting expectations, setting goals, and the positive mindset. And that we could do a whole session on that in its own regard for sure. But if we consider more specifically sort of targeted approaches to the knee, so other types of injections for knee pain control.
That's a great question. There's corticosteroid injections, certainly, that we've used for years and years to manage osteoarthritis pain, right? And there's positives and negatives to that. For diabetic patients, we worry about early blood sugar elevation. We worry about things like steroid flare or inflammation that's caused by the steroid crystal itself. And certainly anytime we're injecting any joint or putting a foreign object into a joint, we worry about the risk of infection. Those same risks come along with hyaluronic acid injections or viscosupplementation injections, sometimes also known as rooster comb injections, but all the same substance. Now the American Academy of Orthopedic Surgeons no longer recommends the use of viscosupplementation injections, not because there's a danger, but because doesn't seem to be much of a difference between placebo and the effects of viscosupplementation. However, I do have patients who absolutely swear by it and get great results. So the data sometimes says one thing, but it's always something I have in my back pocket as a potential treatment option. There are some newer medications or injectable steroids. One in particular is called Zilretta, and it's a triamcinolone acetate that is extended release. So it's bound to a time-release crystal that releases lower amounts of steroid into the joint over a longer period of time. And so for diabetic patients who really aren't a candidate or not ready for surgery yet, but really are still needing some form of pain relief, it's an option for them. We don't seem to see as big a blood sugar spike early on.
Okay, that's interesting. And I guess it's also worth mentioning that for folks out there who are unfortunately dealing with quite a lot of knee pain and looking around on the internet for different ways to manage that, you may also see a number of different injections and other approaches for which there isn't that much evidence. And it's really worthwhile being aware of that and speaking with someone who has the experience, speaking with an orthopedic surgeon or a physiotherapist who really knows their way around these things, because there's a bit of a jungle out there.
Yeah, if you type knee replacement into Google, you're going to get ads about attorneys suing implant companies for failed joints. You're going to get ads about all kinds of devices, from laser devices on down to treat osteoarthritis pain and inflammation. And you nailed it. It is really important to have an open dialogue about not only the potential benefits of those treatments, but the potential risks. Part of that risk is something I like to call a wallet biopsy, which is, are you going to pay a bunch of money for that treatment and get absolutely no benefit out of it? And so that is definitely a risk, especially for patients on fixed incomes who don't have a lot of spare change. It's important to choose the treatments that give you the best chance at affecting your short-term, mid-term, and long-term outcome.
Yep, absolutely. Well, so if we move on this slightly, so we've spoken sort of about the sort of immediate perioperative pain control. How do you go about sort of covering the topic about, when you asked her, well, Dr. Jake, what's the pain going to be like, after those first few weeks, or once the genicular nerve ablation wears off, like what do I do then to keep on top of things?
Yeah, that's a great question. So post-operative multimodal pain control is fairly complex. It's a really evolving field of orthopedic surgery, and it doesn't just involve the surgeon, but sometimes pain management specialists and interventional radiologists and internists. There's an evolving field of perioperative medicine, in particular perioperative medicine specialists. And part of what they do is managing post-operative pain control. And so post-operatively, for certain patients, we're watching your kidney function closer or your liver function closer, depending on your medical comorbidities and overall comorbid risk status. And so I'm tailoring my post-operative pain control to all the things that I know about you, both medically and personally. And so certainly there's a role for opioid-based pain medication. That role is diminishing rapidly, certainly here in the US, but certainly in the UK as well. There's a huge push to help manage pain more effectively with less pain medication. And what we're finding is surgeons is, heck, we can do that. We are getting better at it. So things that we've talked about before, anti-inflammatory medications in conjunction with pain medication, gabapentinoids like Neurontin or gabapentin or Lyrica or pregabalin, those play a role. The data looks a little bit better for post-operative pain management with Lyrica than with gabapentin, but the story is still yet to be written. And then we have ice and elevation, simple things like ice and elevation and compression to keep the swelling down around the joint, managing the things that contribute to the cause of pain, all help in a package to help manage post-operative pain control. And so sitting down with the patient, educating them on what can actually make a difference for them in post-operative pain control is important, because I get a lot of patients who blow off the ice and elevation and think, well, that's not as big a deal for me, or I don't feel good when I have the ice on, it hurts, I'm stiff afterward. Kind of understanding what the potential benefit is of that icing helps you to do it even when you don't want to do it.
Yeah, absolutely. And I think that links in really well with the idea of, while it can be sometimes daunting to learn about different aspects of the procedure, knowledge is power, and knowing a bit more about what to expect, knowing about the things that you can look out for, knowing how and why the things that you can do help, and getting that little bit of a bit of agency as a patient, I think that in itself has a positive impact as well.
Absolutely. The psychological aspect of post-operative pain control is enormous. Positive mental attitude, understanding that what you're going through is going to get better. Talking to your physical therapist and to your surgeon about both preoperatively about your expectations and postoperatively about what you're feeling is really important to helping the surgeon gauge whether they're effectively treating your pain or whether they need to kind of shift some things around. You have patients have trouble metabolizing certain pain medications, and so maybe we just need to simply switch you to a different type of pain medication to help control your pain. Same thing with anti-inflammatory. Some are more effective than others. And so we use psychological forms of pain control. We have certainly direct influence forms of pain control, and then we have systemic forms of pain control. All of them are important.
Yeah, absolutely. And there may also be cases in a while for many good reasons. As you mentioned, there's a move away from using the strong opioid medications, the morphines and codeine and so on. Mm-hmm. In some cases, though, they may be necessary, and it might be the right thing to do. But of course, with there being so much in the news recently about the opioid epidemic and the risks, like what would you say to someone who, where you're having a conversation about different types of pain medication, and they're saying, well, I don't want to go on any of the strong ones because I don't want to become addicted, or I'm frightened of the risks?
It's a really important part of knowing how to use pain medication effectively is about understanding both the risks and the benefits. And so patient education is really important, talking to them about how you become addicted. We use a questionnaire called SOAP, and that asks the patient a series of questions that helps us gauge their potential for addiction. And so knowing that about the patient helps me educate them effectively on how we're going to use post-operative narcotics. Some, like you said, are going to require more than others. Everybody's level of pain tolerance is different. The amount of pain they've experienced in the past is different. So they're bringing different experiences to the table. They're bringing different levels of arthritis and deformity to the table, different amounts of surgical intervention that are required to correct those problems. And then being on narcotics prior to joint replacement is a big red flag for us. We know that we're already behind the 8 ball on our ability to control your pain and also to get you off of narcotics in the long run. So I start to educate those patients immediately. I send a letter to their pain management physician so that we have good communication on how we're going to treat that pain post-operatively together as a team. And again, bringing the pain management specialists into the fold on talking about and treating post-operative pain is really important, both for the patient and for the doctor or the surgeon treating that pain.
Yeah, absolutely. So it again comes back to this, to the term that you mentioned at the very start. It's about multimodal, about bringing in many different aspects. And there's always going to be, you know, the best approach for each individual is going to be different, but it will always be a factor of many different things about social support, about friends and family, about, you know, the positive mental attitude and setting goals and expectations, alongside different types of medications, weight loss, and all these other aspects that we've covered.
Yeah, that's a great summary of what we just talked about. You know, and every patient requires different amounts of all of those things.
That's it. Well, I mean, I've certainly really enjoyed this conversation, and I hope you watching this have too. As ever, if you know, if this has sparked any more questions, or you have a suggestion for another topic for us to dig into in a future Joint School episode, then do let us know in the comments below, or to send it in, and or through the app itself. Dr. Jacob, is there anything else you'd like to say, sort of to sign off this session?
Well, I really appreciate the opportunity, and I'd love to discuss any topics that any of your app users have or want to know more about or want to hear us discuss in detail. I'd be happy to participate in any way.
And we'd be very grateful to have you back. So thank you very much. Thank you for joining us, and thank you everyone for watching. Stay safe out there, everyone, and keep up the good work. We'll see you next time.